Welcome everyone to today's webinar, Chronic Diseases, Health Conditions, and Other Impacts Associated with Rape Victimization of U.S. Women. My name is Susan Howley, and I am the Program Director for the Center for Victim Research. This webinar and all activities of the Center for Victim Research are funded by the Office for Victims of Crime, which is part of the Office of Justice Programs at the U.S. Department of Justice. The Center for Victim Research serves as a one-stop resource for victim service providers and researchers to connect and share knowledge, to increase access to victim research and data, and to increase the utility of research and data collection to crime victim services nationwide. Today's webinar provides important findings about the long-term impacts of sexual violence. And now it's my pleasure to welcome today's presenters. Kathleen Vasile is the Senior Scientist at the Division of Violence Prevention at the Centers for Disease Control and Prevention. She'll be presenting the results of the research. And then Jennifer Grove, Prevention Director at the National Sexual Violence Resource Center, will spend some time helping us think about the implications of this research in advocacy and practice. And now I'll turn things over to Kathleen.
Thank you, Susan. Hello, everyone, and I'm very excited to be part of this webinar today. Thank you for joining. I wanted to start by acknowledging my co-authors on this paper, on this research I'm going to talk about today. Sharon Smith, Jeru Chen, and Larissa Zawald worked with me on this work. Here's an overview of what I will talk about today in this presentation. I'll start with some brief words about the public health issue of sexual violence, what we know about it and its association with negative health impacts, and some of the gaps in our knowledge. And then I'll describe the methods for this study and go through the results and discuss the findings and how they have implications for prevention. And I'll also share some limitations of this study that I'll be covering today. And I think at the end we'll have time for questions later. Okay, so we know from decades of research that sexual violence is a significant public health issue that affects millions of Americans each year. We at the CDC define sexual violence broadly to include any sexual act that is perpetrated without freely given consent. National prevalence data reveals that approximately 1 in 3 women have reported some form of sexual violence victimization that involved physical contact at some point in their life. For this study that I'll talk about today, we're focused on female victims of a specific form of sexual violence, rape, that's defined as physically forced or alcohol or drug-facilitated penetration of a victim without their consent. So we know from the research that 1 in 5 women in the U.S. have reported being raped in their lifetime. A little bit about sexual violence and the association with health. In the literature, numerous health impacts have been associated with rape and other forms of sexual violence in the literature. And it's important to note that many of the impacts of sexual violence can be long-term impacts. In terms of physical impacts, sexual violence has been associated with things like genital and other injuries, abrasions, bruises, and then also serious chronic physical health conditions such as hypertension and heart disease, thyroid disorders, diabetes, cancer, high cholesterol, stroke in adulthood, in addition to disability status and sexually transmitted diseases and other sexual health issues, such as severe perimenstrual periods and pain during intercourse. So sexual violence has been associated with lots of physical impacts. Sexual violence has also been linked to mental health issues. These can include depression, post-traumatic stress disorder symptoms or PTSD symptoms, anxiety, fear, suicidal ideation. And as I said, many of these impacts, particularly these mental health impacts, can be long-term. Sexual violence has also been associated with the receipt of mental health counseling, medical care, religious counseling. However, previous research documents that the majority of sexual violence acts are not reported to law enforcement or disclosed to service providers. Sometimes they're not disclosed to anyone. So sexual victimization has also been associated with decreased likelihood to seek routine medical checkups. Sexual violence victimization can also have an impact on other behaviors and relationships and day-to-day living, including increased absenteeism from work, for example, or increased employee employee productivity and job satisfaction. And I want to make a point that it's important, I think it's important to point out that although some of the impacts may be directly related to sexual violence victimization, like, for example, genital injuries or STD diagnosis, many impacts of sexual violence can occur in the context of cumulative violence by a specific perpetrator. For example, like in the case of an abusive intimate partner relationship or an ongoing child abuse victimization situation. This might be different types of violence by the same perpetrator or re-victimization, sexual re-victimization over time. I think it's important to recognize the collective stress and the associated impacts that one or more forms of violence over time could create, not just fear and injury, but also increased likelihood for the chronic health conditions that I mentioned. So in terms of mechanisms, previous scholarship has proposed different mechanisms by which sexual violence victimization may be associated with poor health. Some have proposed that adverse experiences in childhood and even adolescence lead to a stress response that interferes with the brain architecture and changes responses like behavioral or psychological responses. Another theory is that sexual violence victimization leads the victim to avoid and suppress negative feelings and memories associated with the trauma, which can lead to negative coping strategies that can also lead to poor health. Okay, so what are the gaps that we tried to fill with this particular study? Previous research has described the relationships between sexual violence victimization and poor health, like I mentioned, some of the literature. But many of the studies that exist have used samples with limited generalizability. There's less information available on the associations between severe forms of sexual violence, such as rape victimization, and a wide array of negative health correlates. So this study sought to address some of those gaps by comprehensively examining the associations between rape victimization and health conditions and other impacts among women. And we used data from a nationally representative sample of adult women in the U.S. So in this study, we look at the association of rape victimization with immediate health impacts as well as associations with other impacts and health conditions. So let me share a little bit about our data source. We used data from the National Intimate Partner and Sexual Violence Survey for this study that we fondly refer to as NISFIS. NISFIS was funded and launched by CDC's National Center for Injury Prevention and Control starting in 2010. And in that first year, in 2010, we received support from both the National Institute of Justice and the Department of Defense for that first year of data collection. And NISFIS is an ongoing nationally representative random digit dial telephone survey. It assesses experiences of sexual violence as well as stalking and intimate partner violence among adult women and men in the U.S., and it provides both national and state level data. So for this study, we used the combined data years of 2010, 2011, and 2012, so 3 years of data. Data were collected in all 50 states and the District of Columbia. Interviews were conducted between January of 2010 and December of 2012, and that was a total of just over 41,000 completed interviews across those 3 years. Of those interviews, 22,000, over almost 23,000 were completed by women. NISFIS uses a dual frame sampling strategy, and that includes both landline phones and cell phones. And so for these 3 years, we had 43.3% of the interviews conducted by landline phone and 56.7% by cell phone. And for this study, we used average annual estimates to determine prevalence. So that means we averaged across the 3 years of data. And I want to share the response and participation rates. The overall weighted response rate across those 3 years of data ranged from 27.5 to 33.6%. And the weighted cooperation rate, so that's the proportion of respondents who participated in the survey among those contacted and determined to be eligible for the survey, that ranged from 80.3 to 83.5%. We had a high participation rate. Let me share about the measures that we used in the study. In NISFIS, sexual violence is defined broadly, and it's measured to include several things. We include measures of rape, being made to penetrate someone else, sexual coercion, unwanted sexual contact, and non-contact unwanted sexual experiences. And as I mentioned, for this study, we're focused on one form of sexual violence, which is rape. And given the low disclosure of rape of men in this study, we focused on rape victimization of women, as I think I already mentioned. And just so you know, we're currently working on other studies looking more closely at sexual violence victimization of men. So that will be coming soon. So rape victimization items in NISFIS include completed or attempted forced penetration, also completed alcohol or drug-facilitated penetration, and the penetration can be vaginal, oral, or anal. Okay, so I'm going to move to talking about the measures of impact, health impact that we have in this study. In this analysis, we examined 2 immediate impacts, so that means directly connected to the rape victimization, and those are physical injury, and this could be having bruises, vaginal tears, or other internal or external injuries as a result of the rape, and also contracting a sexually transmitted disease or an STD or infection. We also examined 10 impacts included in NISFIS to see their association with victimization by a rape perpetrator. So this is anything that a rape perpetrator did. These impacts we looked at include, as you see here on the slide, fear, concern for one's own safety, PTSD symptoms, injuries, needing medical care, needing housing services or victim advocate services or legal services, contacting a crisis hotline, and missing at least 1 day of work or school. So these impacts, like I said, are impacts by a rape perpetrator, impacts from violence by a rape perpetrator. Okay, and these are the health conditions that are included in NISFIS that we were able to look at in this study. Several health conditions, and we looked at their association with rape victimization, and we have 11 health conditions measured in NISFIS, and you can see them here on the slide: asthma, IBS, diabetes, high blood pressure, frequent headaches, chronic pain, difficulty sleeping, activity limitations, poor physical and poor mental health, and then use of special equipment, and that could be, for example, a wheelchair, a special bed, or a cane. Okay, so what we looked at is prevalence and population estimates, and they were calculated based on weighted analysis. We took into account the complex sample design features, as I mentioned, the dual sampling frame of landline and cell phone, stratified sampling, and unequal sample selection probabilities. And what we reported on in this study is the following: prevalence of immediate impacts from rape among victims. Those are the 2 measures, either injury or STDs. Prevalence of impacts, those were the 10 impacts from any violence by a rape perpetrator among victims. And then finally, associations between rape victimization and those 11 health conditions that I shared earlier. Okay. This table presents the immediate impacts of lifetime experiences of rape victimization. As seen here in the table, approximately 2 in 5 females who reported having been raped at some point in life also reported sustaining an injury. So that's 39% of rape victims, and that's an estimated 8.9 million rape victims who reported sustaining an injury from that rape experience. such as bruises, vaginal tears, and other external or internal injuries. In addition, we found that 12% of lifetime rape victims reported an STD as a result of the rape victimization, and that's about 2.8 million victims. Okay, and this bar chart presents the impacts resulting from any form of violence by a rape perpetrator. These are the 10 impacts that I mentioned earlier by a rape perpetrator among female lifetime rape victims. And as shown in this figure, we see that 71% of female lifetime rape victims, that's an estimated 16.4 million victims, reported some form of physical health, mental health, or health-related behavior impact. And this is as a result of any violence by a rape perpetrator. So the most commonly disclosed impacts, as you can see here with the bars, the most commonly disclosed were fear, and that was about 65% of victims, concern for safety, which was about 59% of victims, and having PTSD symptoms, and that's about 57% of victims. In addition, you can see here that about 36% of victims reported an injury, and about a quarter of victims reported missing at least one day of school or work or needing medical care. Okay, and this table shares the association with health conditions. And so after controlling for demographics, which included age, race, ethnicity, and education, and also controlling for a previous history of other forms of victimization, and in this we were able to control for experiencing intimate partner, psychological aggression, physical violence, stalking by an intimate partner or a non-intimate partner, and sexual violence other than rape by any perpetrator. So after controlling for all of those previous experiences of violence, these results indicate that the adjusted odds of reporting being diagnosed with certain health conditions were higher among U.S. women who experienced rape at some point in life, and that's compared with women who did not report being raped. These health conditions that were significantly associated with rape victimization included asthma, irritable bowel syndrome or IBS, frequent headaches, chronic pain, difficulty sleeping, activity limitations, poor physical health and poor mental health, and health problems requiring the use of special equipment. As you can see in the adjusted odds ratio column, a strong association was detected with mental health in particular. Victims had higher odds of reporting poor mental health compared to those without a history of rape, and that adjusted odds ratio was 2.2, so it was the higher odds ratio. And as you can see, the only health conditions that were not associated with a history of rape victimization in this study were diabetes and high blood pressure, the ones that do not have an asterisk next to them. Okay, those are the findings. So now I'll make some discussion points here. This study is the first, to our knowledge, that uses a nationally representative sample to examine immediate health impacts resulting from women's rape victimization, other impacts of violence by a rape perpetrator, as well as numerous health conditions that are associated with rape victimization. So regarding the immediate impacts, we found about 2 in 5 female victims were physically injured, and over 1 in 10 contracted. Of the 10 impacts we measured, findings indicated that over 70% of victims suffered some type of impact resulting from violence by a rape perpetrator. As I mentioned earlier, PTSD, needing medical care, et cetera. In addition, 9 of the 11 health conditions that we were able to examine in this study were associated with a lifetime history of rape victimization, so the majority of the health conditions. So the lack of observing history of rape victimization and high blood pressure, that's actually consistent with previous research, and to us it suggests that high blood pressure may not be directly associated with sexual violence. This study also revealed no evidence of an association between rape victimization and diagnosed diabetes, which may only, it could be that it's only indirectly associated with sexual violence through obesity. In addition, this study showed that rape victims often report that the violence by the rape perpetrator, including rape and other forms of violence, resulted in fear, concern for safety, PTSD symptoms, and the need for numerous services. So it could be that these rape perpetrators, in some cases, are also perpetrating other forms of violence, such as in the case of intimate partner perpetrators. And so in some cases, it might be the combination of these forms of victimization that's leading to these numerous health impacts. So this study, like all studies, I think, has some limitations. I'll go through some of these. The random digit dial telephone surveys exclude, obviously, those who do not have a phone or those living in institutions like prisons or other institutions. So we may be excluding some high-risk populations, such as those in prison or those who are homeless, for example. A second limitation is due to the cross-sectional nature of the sample. We cannot determine directionality between the health conditions and the victimization. However, victims attributed the immediate impacts that we measured, the physical injury and the STDs, directly to the rape victimization. And some of the other impacts included, like PTSD and fear and the others, were assessed in relation to a specific rape perpetrator and any of the victimization experienced from that perpetrator. A third limitation is given the way the data were collected about all victimization experiences by a given perpetrator. We cannot exactly isolate the rape victimization when examining the health impacts, but we know that they were related to what that perpetrator did, the perpetrator who committed rape. Fourth, our estimates are considered underestimates, and I think this is true for most research of this form, in terms of telephone surveys. Due to the sensitive nature of the survey questions, some women may not have felt comfortable disclosing their victimization, so we suspect these are underestimates. Fifth, in this analysis, we did not take into account the difference in health impact between those victims who were raped once compared to those who were raped more than once. So we did not account for frequency in this study. Finally, despite strategies implemented to encourage survey participation, the overall NISFIS response rates were low, but the fact that the cooperation or the participation rates were high indicates that over 8 out of 10 eligible adults chose to participate in the survey. So that suggests to us that the violence topics might not have systematically influenced a certain group of adults to drop out of the study. Moving to future research, in terms of future directions for this kind of research, we think it would be beneficial to conduct future research that looks longitudinally at direct and indirect relationships between different forms of sexual violence victimization and later health outcomes, as well as the specific circumstances that may actually protect victims from adverse health and other negative impacts of violence. And it would be particularly useful, we think, to examine this among high-risk populations that may not have been in this study and that we may have missed in this national telephone survey. And I'll end with some implications for prevention. Primary prevention of rape and other violence is a critical undertaking for us at CDC and for the field to improve societal health and to reduce long-term health and other costs of victimization. And we focus quite a bit on that in our work. So, and resources are available to aid with prevention. For example, we have a link here on the slide for the 2016 publication by CDC. It's called Stop SV. It's a technical package for preventing sexual violence, and it compiles sexual violence strategies, prevention strategies with the best available evidence to consider in a comprehensive strategy for preventing sexual violence. These strategies cut across the social ecology. They include focus on individual level, like teaching skills to prevent sexual violence, also relationship level approaches like bystander approaches, and community and societal level approaches like changing the physical environment or focusing on policies that may prevent sexual violence. So as I mentioned, the link to the technical package is included here on this slide, so please check this out if you're interested. in getting more information about the most promising ways to prevent sexual violence. And finally, screening for violence victimization and trauma-informed integrated health care that incorporates areas such as STD testing and treatment is also really important to reduce negative outcomes when sexual violence occurs. And that does it for me, and I think we have time for some questions now if we'd like, or we can move on and have questions later.
Kathleen, this is Susan. A few questions have come in. Folks, go ahead and enter any additional questions you have in the chat box. First of all, we know that NSFIS is a continuing survey, but are there currently plans to update this health information periodically?
So yes, NSFIS is ongoing, and these data are from 2010, 11, and 12. We have newer data that we're trying to, we published 2015 data that had a smaller sample size, and we have data from 2016, 17, and 18 now that we're working to get out in a report. So yes, these health conditions and these impacts are included on all those years of the survey. So as you noticed, we had to include 3 years of data to look at some of these things. You need a big enough sample to look at these associations. So as we collect more data and are able to analyze that data, we will be looking at, continuing to look at these associations with health and health conditions as we move forward with NSFIS.
Thank you. Another question. One of our participants is wondering whether your list of impacts included short or long-term self-medication with alcohol or other substance uses.
That's a good question. It did not. We are in the process of revising NSFIS, doing I'm trying to think of the word that we're using. It's kind of a reset of NSFIS where we're looking at different ways to ask the questions that may not be a telephone survey. So we have been revising the instrument a little bit. The challenge is we can't include all the impacts that we know from the literature are associated with these types of violence victimization. What I'm not sure about is if we include anything more on substance use in the revised survey. It's possible. We didn't have it in the years that I presented on today, but it's possible that it may be in future iterations of NSFIS. But like I said, we have just really a sampling of all the health conditions and impacts that could be associated with sexual violence and other types of violence measured in NSFIS because there just isn't enough room in the survey to ask all those questions, all those types of impacts. But it's a good question and a good point and an important impact that you mentioned.
Well, relatedly, and you may have the same answer for this, what about the impacts of suicidal ideation or self-harm behavior?
I believe that, so we don't have that in the 2010, 11, and 12 that I presented on, but I believe we are considering adding that in a future iteration of NSFIS. Like I mentioned, NSFIS is in a revision period right now, so there'll be a little bit of a delay in the data years. But when that does come out, if we get approval and it moves forward, and right now, I believe we will have at least some measurement of suicidal ideation. I can't promise everything that was mentioned in the question, but we do recognize that as an important area, and it's currently one of our priority areas in our center at CDC, so we agree that it's an important thing to measure, and hopefully we can.
All right, we've had a couple of people interested in the demographics of the survey and whether there were any differences across ethnic groups.
So there are differences that we've published in our kind of general summary reports in terms of differences in victimization by racial and ethnic group. We find overall in general that racial and ethnic minority groups have higher prevalence of rape and other types of sexual violence than white respondents. we controlled for race ethnicity in this study, but we didn't look at differences in this particular study where we're looking at the association of rape with impact. I would suspect there are differences, but it wasn't a focus of this particular study. But like I said, if someone is interested in racial and ethnic differences in victimization prevalence, they can look at our NISPIS website where we have all the summary reports where we do look at victimization prevalence by race ethnicity.
Thank you so much. I think that's it for the research questions at this point, although folks, oh no, another question has come in. Do you know about any current research on the percentage of sexual assault survivors that have engaged in self-harm behaviors outside of your own research?
I don't, I'm sorry. The only thing I can think of is there have been some YRBS, the Youth Risk Behavior Survey, does include sexual violence, and it also includes suicide ideation and some suicide risk behaviors. And there was a study that I was involved in using 2017 data that looked at the association with sexual violence, victimization, and different health risk behaviors, including the suicidal ideation. So that would just be among youth, though, high school age youth. I'm sure there's other studies. I can't think of others with adults off the top of my head. But if they're interested in that youth study, I can send a link, or we can get that information out.
That's great. And you mentioned that that this study didn't capture all of the impacts, but we had a question come in. Has there been any look at the connection between sexual violence and eating disorders?
Unfortunately, we don't have the space. We don't have those types of questions in NISPIS, but the YRBS study that I just mentioned also had that as one of the youth risk behaviors. So if they're interested in youth, I can share that study. I know there's been work on that, but it's not. We don't have those questions in NISPIS, so we can't show that link with this data.
All right, well, Kathleen, thank you so much for that summary of research, and I'm sure there will be additional questions at the end. But we can turn now to Jennifer Grove for the practitioner or advocate's perspective.
Thank you.
Hi, everyone. Can you hear me okay?
Yes.
Okay, great. I apologize. I have a lot of ambient noise. Most people have children in the background or dogs. I have a lot of birds outside my window. So even if I close my window, sometimes I have people when I'm on webinars or conference calls say, oh, what's that bird sound? So hopefully that it's not too disruptive for folks. So I just want to say I'm really excited to be here and happy to be working with Susan and her team, as well as Kathleen. Kathleen and I have worked on some previous webinars together around CDC research, and the National Sexual Violence Resource Center is funded primarily by the Centers for Disease Control and Prevention through their Rape Prevention and Education grant program. And so, again, excited to be here today to talk a little bit with you about some commentary, reactions. I see some questions that have come up, which in the text chat, which I think some of the same things that I'm thinking, some questions and thoughts that I have as well. The first thing I do want to say, though, is that for myself, as well as the National Sexual Violence Resource Center, we're very thankful and grateful for the National Intimate Partner in Sexual Violence Survey, NISPIS, and CDC's ongoing commitment to that national survey and data collection. It's desperately needed. When NISPIS data first came out in 2010, we were really, really excited because for years we had really been struggling with a lot of outdated data and data that really didn't bring into context a lot of things that we knew people wanted more information on. And so it's been very valuable to the field of sexual violence, both intervention and prevention. And data like this really helps us to define the problem so that we know how to prevent it. I kind of want to start there because as an advocate and a preventionist, I would be remiss if I didn't start off by commenting on the prevention implications of this research. As Kathleen talked about primary prevention of rape is critical to improve societal health and also to reduce the long-term cost of victimization. And so for us, this means that working at those outer layers of the social ecology is very important. Things like Kathleen was saying, things like at those outer levels, like laws and policies and these bigger outer level things like working with communities to create protective environments where violence isn't tolerated or isn't the norm. For anyone currently working under the Rape Prevention Education Grant in your state, that's where our focus is right now, is on some of those community level and society level strategies for prevention. And it's so important that it's also important, secondary prevention strategies are important as well. Thinking about things like screening. We know there are some states where screening for sexual violence and intimate partner violence is the norm. In some places it's mandatory. And then of course thinking about other forms of secondary prevention like access to advocacy and counseling service. Again, those things are important in reducing the trauma and the impacts of rape. So one of the things that came up for me while reading this research is a question about training for healthcare professionals. One question that I had, and I don't really know the answer to it across the board, but are healthcare providers trained on the connection between sexual violence and health outcomes? And thinking about the impact that this might have with practitioners and their work, are there ways that practitioners can better partner with medical schools, with nursing programs, other healthcare training programs? Are there ways practitioners can help by doing some cross-cutting training? We know that this does happen in some communities. I know NSVRC has been tasked with developing some online learning tools and webinars for specific medical training programs in the past. So a question I have for you, and when I'm asking these questions, I know we are going to be moving through this fairly quickly. So one of the questions that I had, which I would welcome you to put some responses in the chat, and this is really for everyone on the call, for everyone on the webinar's benefit, to see what resources you're tapping into or what you're doing. Are you currently doing training for healthcare providers? And if so, what does that look like? Screening is also a really good way to evaluate the needs of patients and provide intervention and prevent adverse health consequences of sexual violence. A thought about this, though, is once that someone is screened and identified, how then are victims connected to services? One of the things that I know for me personally, when I'm going to get to healthcare appointments, I routinely, will get the screening questions, and most of my healthcare providers are now familiar enough with me that they know I'm going to stop and ask, what are you going to do with that information? If I say yes, what is your next step? Are you going to be referring me somewhere? What does that look like? Once someone is identified, how are you going to connect me to a service if that's something that I need? We know that screening tools, and someone asked this, Angela, you had asked this earlier in the chat, are there any great screening tools out there? I know that there are many screening tools available. I wanted to highlight a few of the resources that we refer to a lot. One of the resources is IPV Health. It's the Futures Without Violence resource. They have, on this website, there's a lot of great resources on screening tools, but also on this piece around advocacy and healthcare partnership development, right? So how do we build partnerships between the advocacy world and the healthcare world? It is focused on intimate partner violence, but it's still very relevant, and there are, of course, intersectionality between sexual violence and intimate partner violence. I think there's a lot of great resources. There are resources specifically for DV and SV advocates on this site, and And I will put my email at the end if, I don't know if we'll be able to maybe send you a list of resources, or if not, you can reach out to me directly and I'm happy to send you some of these links. We also at the National Sexual Violence Resource Center, we have a screening tool that we developed, Assessing Patients for Sexual Violence, a guide for healthcare providers. And I also wanted to mention a very unique guide on screening and partnership development by the Virginia Sexual and Domestic Violence Action Alliance. It's the Reproductive and Sexual Coercion Toolkit for SV and DV advocates. This toolkit is really unique in that it gives some resources and ideas on building agency capacity around reproductive and sexual coercion. It offers some screening tools, sample policies and procedures, and it also has a component where it talks about how to foster partnerships with family planning and reproductive healthcare providers. And I'd love to hear if you have, for you to share in the chat, and maybe you're already doing this. It's hard for me to keep up with the chat while I'm talking, so, but if you have specific resources that you use for screening, that would be great if you could share those in the chat for everyone to see. In the research findings, I thought it was interesting that fear and concern for safety are high, as well as injury is high, but medical care, legal, advocacy services, contacting crisis hotlines are low, and it makes me wonder about the significance of this. Does this tell us that access is an issue, or maybe knowledge of the services that are available, maybe that's low? So a question that I have that this brings up for me is, how can we build those connections to services? How can we create those bridges, those partnerships, so that people know that services are available? We think about, I know I worked for many years as an advocate in local programs, and one of the main things that I did was to help with our sexual assault response team. And so we worked really closely with sexual assault nurse examiners, and I know when there's an emergency exam done, sexual assault nurse examiners can be amazing, wonderful bridges and connections to services. And so I think that happens in a lot of communities, but in general, if people are going to their healthcare provider, being screened, again, you know, are people knowledgeable about what services are available and if services are even available and what that looks like. So that's also something for us to think about. We've been having a lot of conversations. I've seen some of this coming up in the chat when Kathleen was talking, and one of the things that we've been having a conversation about lately is health disparities and health inequities and their connection to sexual violence. So health inequities and their impact have become a lot more visible in light of the current COVID-19 pandemic. Every day, I think in my inbox, I have a series of articles, of resources, of things that are coming through about the connection between health equity, health inequities, health disparities, and COVID-19. It blends so well in with our discussions, our current discussions around how this is all connected to sexual violence. And one thing that we've come to realize, and I think a lot of our partners are coming to realize, is that violence is a health disparity. We have to work to remove obstacles to health. Things like poverty are obstacles, you know, discrimination, lack of access to things like fair pay and quality education and housing and safe environments and healthcare. I really like this Prevention Institute quote: "Violence and fear of violence are major factors that undermine health and worsen health disparities." And thinking about this in connection with the research findings that Kathleen just shared with us about fear, you know, how can advocates work with victims to address this? You know, some safety planning tools can be a good first step, but do our safety planning tools take into account things like health disparities and health inequities and what survivors do and don't have access to? I know that one of the things we are talking a lot about is what about these marginalized groups? We know that sexual violence disproportionately affects people of color. It disproportionately affects young people, people with disabilities, people who identify as LGBT, and on and on and on. How do we make sure people who are quote unquote at the margins or outside the margins aren't pushed even further out? Just today, and I'm happy to share this too, the National Resource Center for Reaching Victims just did a series of COVID-19 impact briefs looking at the impact on underserved victims of crime. I'm so excited to dig into that because I think, like I said, like the current pandemic is really shedding a light on health inequity in our country. And I think that, you know, we also are asking questions about how does structural and institutional racism play a role in the health outcomes for sexual violence. And so one of the questions we had too was around, you know, are there plans for studies on health impacts in connection to gender and race and ethnicity? We would really love to see more studies looking at this. And I know some of you in the chat earlier were saying the same thing. What are those connections? So I think more research and studies looking at the health outcomes for specific ethnicities, gender identity would be amazing to have that information. So in thinking about this, think about like how do we make sure our services as practitioners, how do we make sure our services are accessible and designed to meet the needs of all survivors? And so I would love to, if you have ideas or thoughts on this or things that you're doing, to share that in the chat as well. What are some ways that you are doing this? Have there been some challenges? How have you overcome those challenges? But in thinking about the groups of people who we know are on the margins, the groups of people who we know are being left out of these conversations, how are we designing our services so that they're accessible to everyone? And then, just checking the time here, last but not least, I do want to say in all of this, in all of these health outcomes and everything that we're discussing today, we really need to remember how resilient survivors are. I'm always amazed, and I think that we as practitioners have a particular role in supporting this resiliency. We have some research out there. There's research on what's called the resilience portfolio model. There's research on resilience in child sexual abuse survivors. And this research is really looking at what are those, help us like understand these protective factors, these processes that promote resilience in children and adults who are exposed to violence. Really looking at what are those protective factors, what are those connections that people need. They need support from family, they need support from a wider social environment. What are those things, and how can we as practitioners provide those things to survivors to promote their resiliency? But I do want us to always remember like just how resilient survivors are in you know, in spite of everything that they experience. And so with that, I do want to just put my email up here because I've put a lot of information out there. I've given you a lot of resources and ideas and things to think about, but I love to be able to connect people with resources. I love to hear about ideas that you have or resources that you have. We love to add new things to our collection of resources. We have a huge library, the largest library on sexual violence in the world. And so we would love to know more about what you're using, what you're looking for, if we can connect you with resources. Please feel free to reach out to me. My email is here, jgrove@nscrc.org. Yeah, so that's my presentation. I don't know if there are further questions that people have.
Thank you, Jen. And yes, there are a few questions, but before we get to those, I just want to give credit and my thanks to all of the participants you are all being so generous in sharing your experience and your resources in the chat. It's been really a pleasure to follow along. So Jen, a comment came up when you were talking about medical education, where the participant noted there's too much room for assumption that the victim will reach out. Often, as we know, that is not the case. Do you have a reaction to that?
No, I would say that's very true. I mean, we know that most victims don't talk about it. Most victims don't come forward. And so I would just say I agree with that comment. But I wonder, too, what barriers are there, and how can we help to remove some of those barriers, whether it be the way that our services are set up, whether it be the fact that we aren't making the connections and having those partnership building opportunities with our healthcare providers. Like, what can we do to make it, I don't want to say easier, but I don't know another word, for people to come forward and seek services. I think we're still not off the hook, but it's very true that it is a lot for someone to come forward.
Another question that has come in: how can we educate the medical practitioners to do better screening, and how can we identify the barriers to break down?
That's a great question. I think there are, like I said, I mentioned a few resources, and I think some of those resources have some good capacity building tools incorporated into them. So I think it's a matter of really looking at what resources are out there and yeah, trying to make those connections, trying to build those partnerships. I can't stress enough, I think it can happen, but I know that it does take a lot of time. And that's something that in the advocacy world, we don't have a lot of times, because we're so busy responding and keeping up with all the work that we need to do, that it does take time to have some dedicated time built into building our own capacity, but also then making those connections and partnerships so that education and cross-training can happen.
All right, I'm going to ask our webmaster to launch the exit poll just so it's there if people have to leave, but please continue to enter your questions in the chat box. Kathleen, another question has come in regarding NSFIS. As NSFIS looks at male and female victims, are there plans to expand it to transgender or gender nonconforming? Or can you recommend additional rigorous surveys that explore that population or those populations?
That's a good question. And we, for the first few years and the years of NSFIS that I presented on today, we did not have measurement of transgender. We did have sexual orientation questions in there, but not transgender. And in later versions of the survey, and I believe the current version that's being piloted now, we do include that. I was trying to confirm that with the lead of NSFIS, but I believe that we do include transgender. The challenge with doing analysis with transgender population or part of the sample is that we need a large sample size to be able to look at estimates. So we would probably need to look at several years of data gender measurement in the survey. We probably have to combine several years of data. So it may take a few more years to have that, but we do hope to have that in the future.
Thank you. Another question that came in, I believe that your presentation noted that a rather low number of respondents, 7%, said that they contacted a hotline. Are there any studies that you're aware of that show higher rates of hotline utilization?
Not off the top of my head. One study that the person might want to look at is the work by Dean Kilpatrick. It's a few years old now, the one that I'm thinking of at least, but I think it looked at several impacts of rape and sexual violence. I guess, yeah, it is low in this survey, but this is a nationally representative sample, so it may not, it's a cross-section of the population, and I think I would guess from the literature that those who use a hotline are those who have very severe cases of victimization and probably in many cases ongoing abuse or like an intimate partner relationship where it's ongoing abuse. And that, you know, what we're looking at here is mostly focused on rape. But even in our national, in our NISPIS summary reports, we still find a low number of folks who are reporting that they're using a hotline. Yeah, I'm not, it might be something to do with sample, but I'm not aware of other studies that have found a higher rate, but there may be others out there.
Thank you. And one of our participants just wanted to confirm you were talking about Dean Kilpatrick, if they want to look up information.
Yes, yes. And it was from a few years ago, so it may not be as current, the one that I'm aware of and familiar with, but there may be something more recent. Dean Kilpatrick and his colleagues have done some work on impacts of rape.
All right, it looks like that is it for the questions from our audience. I want to thank both of you. This presentation has both given us knowledge to do our work and helped stimulate a lot of creative thinking about how we can use this knowledge and activate more allies in this effort. So Kathleen, thank you so much. Jen, thank you as well. Do you have any parting thoughts?
No, just that I'm so glad to be a part of this webinar, and thanks so much for everybody who attended.
Yeah, I agree. I just wrote in the text chat, thank you so much to everyone for your thoughtful responses. I was just reading through them quickly, but it looks like a lot of great resources were shared in the text chat as well. So thank you all, and thanks for the invitation to be here.
All right, thanks so much, folks, and for your time today. And we'll be distributing these resources and a recording. Thank you and goodbye.